Hi, my name is Nasser Kabak, and I'm Associate Professor at the University of Science and Technology, International University of Science and Technology in Damascus, Syria. And today's lecture is about tissue management and impression making. It's for undergraduate students in Fixed Proshtodontics. We have a channel on Telegram. You can visit it for different topics regarding the Fixed Proshtodontics subject. And why is this subject very important? Why is taking the impression and tissue management important in the aspect of treating the patients? Well, good impressions will lead to good restorations. And if the gingival tissues are inflamed, this will lead to bleeding, will lead to distortion and errors in the fabrication of the restorations. This will affect, of course, the crown fit and the longevity and the patient's comfort. What has been changed in the recent years? Well, the introduction of digital impressions and digital scanners. Also, retraction pastes will substitute in some areas the retraction courds. Some terminology has been changed. For example, supracrestal tissue attachment has replaced the biologic width. And of course, the minimal invasive dentistry and the biomimetic dentistry also as a new school of thought in dentistry. Today, we are better in understanding the tissue biology. For example, we can tell the difference between thick and thin gingival biotype, and accordingly, we will take the appropriate decision regarding the materials and the techniques that are used for each different type of gingival types. So learning objectives for this lecture will be the student should be able, after finishing this lecture, he should be able to, well, at least tell the difference between the different structures in soft tissue biology and how he can manage the tissue safely. What are the methods for gingival displacement? And we should also be able to state the impression materials, the different types of impression materials, and the different impressions regarding the conventional and digital types of impressions. And this is why, after understanding all these things, you should be able also to take the decision, the clinical decision regarding each clinical scenario. So the main topics of this lecture will be biology, gingival displacement, impression materials, impression techniques, and digital impressions. So let's start with biology, and let's start with the gingival anatomy. As well, dentists interested in prosthodontics, we should understand that this is an apparatus that, well, protects the bone and protects the gingival tissues from recession or from inflammation. It's the free gingival margin, it's the gingival sulcus together with the junctional epithelium and the connective tissue. All of these are called the supracrestal attachment area. Previously, they were called the biologic width. So this biologic width constitutes of the sulcus, which is around 1 millimeter, then the epithelial attachment, also 1 millimeter, and finally the connective tissue attachments, another 1 millimeter. So if you join them, these structures constitute of 3 millimeters. In other words, the margin of the restoration should be far away from the bone by at least 3 millimeters in order of these tissues to live in health and in good conditions. And if we violate this space by introducing the margin of the restoration deep inside the gingival tissues, we'll violate the biological width, and subsequently either the gingival tissues will inflame and this will lead to hypertrophy, or the gingival tissues will reside and this will lead to gingival recession. So the response of the tissues to restorative procedures is important, since if you have bad fitting temporary restorations, they will lead to trauma and they will lead also to bleeding. Poor temporaries will lead to inflammation, and overhang margins that extend beyond the restoration texture or restoration, well, geography, they will lead to swelling, and they will lead also to pressure on the gingival tissues and finally damaging the tissues. So what are the factors that will affect the tissue's health before impression? First, the compliance of the patient and the plaque control. This is very important. The patient should understand his role regarding the health of the gingival tissues. A proper provisional restoration is mandatory also, with smooth margins and adequate emergence profile. Well, the emergence profile is this part of the crown where it meets the gingival tissues, and if it's properly executed, it will lead to proper gingival health. The margin of the restoration should be kept away from the gingival tissues whenever is possible. This will guarantee the long-term stability of the gingival tissues. But sometimes we need to place the gingival, the tissues, the crown margins on the level of the tissue, and sometimes also subgingivally. So in certain situations, when we need to have good emergence profile and aesthetic reasons, it's better to place the margins of the restorations subgingivally. And in these situations, we should be careful not to damage the periodontal tissues. When tissue management is needed, of course, if I have supragingival margin, there's no need to place any courd, and the gingival retraction is no problem at all. But in subgingival margins, when you have gingival inflammation or deep caries or crown lengthening procedures, or we need to take digital impression for deep margins, in these situations, I should take into consideration that there are a few steps that should be done in order to guarantee the access of the impression material or the digital scanner for these deep areas. So the main topics of this lecture will be biology, gingival displacement, impression materials, impression techniques, and digital impressions. Gingival displacement and what are the methods of gingival displacement. At first, what is gingival displacement? It's temporarily moving the tissues away from the tooth. We are opening the sulcus to expose the finish line and also to control moisture. It's well known that most of the impression materials, final impression materials, are hydrophobic. So the control of moisture plays a great role in the polymerization of the impression materials and in the success of the impression materials in overall. So what are the goals of gingival displacement? Clear margin visibility. All the margins should be visible in the impression and before also the impression. Dry field, minimal trauma, and stable sulcus during impression. What does it mean, stable sulcus? This means that during taking the impression, the sulcus should remain open for 30 seconds in order for the impression material to be introduced inside the sulcus. There are different types of retraction methods. Some of them are mechanical, retraction cords non-impregnated. This means that without any medicament are called non-impregnated retraction cords. They can be placed inside the sulcus, either with single cord technique, just one ply of the cord will be introduced inside the sulcus. Sometimes double cord technique is used by placing a small cord inside the sulcus and then the large cord over it. There are different types of cords, but when we use non-impregnated retraction cords, this means that we are using the mechanical method. This cord will absorb the fluids and subsequently it will enlarge the area where it sits, and this is called mechanical method of displacement. So retraction cords have different types. Some of them are knitted, some of them are braided, some of them are twisted. The twisted have an advantage that we can take some, for example, a few plies and place them inside the sulcus without damaging or enlarging the sulcus too much. Chemical agents can be used also as vasoconstrictors, for example, epinephrine, but it's less used today. There are a few courds, such as gingival, that are impregnated with vasoconstrictors, but it's preferable to use aluminum chloride since the vasoconstrictors are contraindicated for the patients with hypertension. Another material, ferric sulfate, also can be used, but it's a little bit, not well tolerated by the sulcus, and its color is dark. It's very effective, but I think working with it is a little bit problematic since it has yellow color and it can't be rinsed easily from the sulcus. So we have different terms in these situations. Haemostasis means that we are stopping the bleeding. Astringent means that the constriction of the blood supply that will lead to this area, to this critical area, and of course the enlargement. So each medicament and each method has its different purpose. Some of them have hemostatic capabilities, some of them are astringents, and some of them will displace and open the sulcus by gaining space inside these areas. Retraction courds have different classifications. There are other techniques, cordless retraction systems or the paste that can be used in order to expand the sulcus and also to achieve a sort of hemostasis. Aluminum chloride is the material of choice. When it's injected inside the sulcus, it will lead to temporary displacement of the tissues and opening of the tissues. And if the tissues are healthy, they will regain the size and the level of the attachment. So what are the indications of these pastes if the sulcus is shallow, not so deep, and when the tissues are healthy? If there is great inflammation and deep, pockets, let us say, it's better to use the retraction cords, and of course it's better to heal these tissues before taking the impressions. This is a video regarding the taking of the impression with Expazen. It's a sort of a capsule that is placed inside the composite gum, and different brands have different tips and different viscosities. After introducing it inside the sulcus, we should wait 2 minutes, and then it will be, or it should be removed. Its consistency is thick, so we should rinse it carefully. And these are the exposed margins that are ready for the impression materials to be introduced over them. Laser-assisted retraction, which is a surgical method, and it's called troughing, also is a method to open the gingival sulcus, but it's a little bit expensive, and it has also an advantage that it provides instant hemostasis. It's useful for the deep margins, but not all the clinics have the capability to buy a laser device. Electrosurgery is also another method. It's an old technique but still used till now. Unfortunately, there are risks for using electrosurgery. For example, recession or the damage of the gingival tissues by heat. There are a few precautions and considerations that should be taken during the electrosurgery. First, any patient who has pacemaker, these devices that are used to stabilize the pulses of the heart, uh, it's contraindicated for these patients to use electrosurgery. Thin gingival biotypes also are contraindicated, since if we cut the gingiva in these situations, it might recede and not go back to its original place and level. Metal instruments also, we should be careful to take plastic mirrors and to work with plastic instruments during the use of electrosurgery. The patient should be anesthetized deeply, and during the cutting of the gingival tissues, rapid single strokes should be used, and we shouldn't repeat the stroke within 5 seconds. So make a stroke, wait 5 seconds, and then another stroke. And this is why these electrosurgery surgical devices are not so widespread in the clinical situations. Uh, so how to manage the bleeding? We can put pressure over the gingival tissues. The hemostatic agents also should be used. Good temporaries are important, and avoid the trauma from the gingival tissues. Anesthesia to the papilla also is a good way to stop the bleeding, and it's my preferable way. I take 2% lidocaine with epinephrine 1/100,000, and injecting this solution with small amount in the base of the papilla will lead to instant blanching and instant, haemostasis for a short period of time, but this short period of time will be enough to introduce the impression technique or the impression material, and also to do whatever we want within this small window of opportunity that will guarantee the dryness of the sulcus. Choosing the right method depends on the health of the gingival tissues. If the gingival tissues are healthy, we might use the pastes. If the depth of the sulcus is moderate, it's better to use single courd. If it's too deep with horizontal preparation, it's better to use the double courd techniques or the laser. And the digital scanners also need a sort of retraction courd, despite that they are digital scanners, but unfortunately, the scanners cannot see in places that are closed or dark. So the sulcus should be open when we use digital scanners. Matching the retraction courd to the impression type. So if I use an intraoral scanner, there's need for the light to enter inside the sulcus, and this is why it's better to use the paste or a small courd or double courd technique, for example, for deeper margins, but removing the upper part of the courd before taking the intraoral scan, the impression of the intraoral scanner. On the other side, if you are using elastomeric impression materials, vinyl polysiloxane, it will require more circular space, and this is why it's better to use retraction courds. Retraction pastes do their job at best in healthy tissues and small sulcuses or sulci, while the deep margins necessitate the use of retraction courds. Sometimes we might use the courd with the paste. There are some errors that can be committed by the dentist during tissue management. Sometimes we pack the cords too forcefully inside the sulcus. We leave the cords for too long of time. We use strong chemicals, and using the burrs in non-well balanced way also might damage the gingival tissues. One method that uses the burrs to open the gingival sulcus is called the biologically oriented preparation technique, making a vertical finish line or feather edge, gingitage sometimes it's called, and it necessitates the placement of a good, well-fit temporary crown in order for the gingival tissues to heal over this matrix of the gingival level on the gingival level. So the main topics of this lecture will be biology, gingival displacement, impression materials, impression techniques, and digital impressions. Impression materials. Different types of impression materials can be used to capture the details inside the sulcus and all around the margins of the preparation. These materials should resist distortion and transfer accurately the information to the lab. Regarding the clinical decision taking, when to use intraoral scanners, IOS, and when to use silicones. Of course, intraoral scanners nowadays are so popular, and new brands are continually emerging with better accuracies and with, well, cheaper versions. But till now, full mouth rehabilitation is better done with silicone impression materials. The long span fixed prosthodontics and full arch impressions are better done with silicones. The intraoral scanners are used for single crowns, short span bridges. Sometimes post and core can be taken. The impression of a post and core can be taken for narrow canals. And if the patient has gagging reflex, the intraoral scanners are very important in these situations. Of course, the digital workflow means that CAD/CAM restorations and aligners, and the dentist can, well, take the impression with the scanner and subsequently revise his work and plan his work digitally without taking any other analog impressions. This is called the digital workflow, and it's important, but till now it's not widespread. Classification of impression materials. We have rigid impression materials and elastomeric impression materials. The elastomeric impression materials, some of them are hydrophobic, such as C-silicones. Some of them are hydrophilic, such as polyether, and we will shed the light over these materials. Of course, alginate is not suitable as a final impression material. It's for preliminary impressions, and it's called, well, hydrocolloid or irreversible hydrocolloid. Between C-silicones and A-silicones. C-silicones are intended to be used as duplicating materials. Nowadays, they are replaced by A-silicones, which are, well, mechanically better performing. They are hydrophilized also, the A-silicones. They can be automatically mixed, and their stability, and also they can read the details better than C-silicones. But C-silicones are cheaper, and also there are a few advantages of C-silicones, such as we can a little bit play with the amount of catalyst. If we increase or decrease the catalyst, we can control better the mixing time. But this is not a great advantage. After all, A-silicones are the best materials that are used nowadays in dentistry in order to take the final impressions. So when we say vinyl polysiloxane, this means addition silicone. They are the most common nowadays. They are very accurate with good dimensional stability, and they are hydrophilic. In order to understand what does it mean hydrophilic or hydrophobic, imagine that we have a surface and we are not sure about this surface if it likes water or not. If you place a droplet of water over this surface, and this droplet of water becomes like a dome, and we measure the degree, we call it the contact angle. if it's around 90 degrees, this means that water hates this surface and this surface is hydrophobic. On contrary, if the droplet of water spreads over the surface and we measure the contact angle in between this droplet of water and the surface of the material, and it's an acute one, for example 15 degrees, we will call this material hydrophilic. So most of the elastomeric impression materials are hydrophobic. This means that they hate water, and in the oral environment we need hydrophilic materials. So how come that aceticones are nowadays hydrophilic? The manufacturers have placed a material which is called surfactant. The surfactant makes the addition silicone hydrophilized. It's not hydrophilic by nature, but it's hydrophilized because of the presence of the surfactant inside the chemistry of these materials. Another advantage of vinyl polysiloxane is the command cure or the heat cure. When we introduce the impression material inside the mouth, it takes the heat and it starts to polymerize according to the temperature of the mouth. So outside the mouth, it is runny and the viscosity is fluent, no problem. On contrary, if you are using C-silicones, the C-silicones outside the mouth, by the starting of the mix, they start to harden and the viscosity becomes stiffer and stiffer and stiffer. So this is why aceticones have plenty of time in order to take the impression without taking into consideration the differences in the working time outside the mouth, because you have plenty of time to introduce the acetylcoin inside the mouth, and once it's inside the oral cavity, it will be commanded by the heat and by the temperature of the oral environment to start the chemical reaction and to set. Toughness is also important. Aceticones are tough and mechanically strong materials. Why it's important to have a tough material? Because when it's taken out from the mouth, and if it stuck in undercuts or in the interproximal areas, it might tear in these areas and distort. So a good impression material, elastomeric impression material, should be tough in order to remain stable at this stage of removal from the mouth. Detail reproduction also is important. How can we measure detail reproduction? By introducing the material inside grooves. These grooves are with different depths. For example, alginate is capable to reproduce a groove with a width at least 75 microns. On contrary, elastomeric impression materials have greater detail reproduction, and this is why they are able to reproduce a groove of 20 microns. So this means that the sharp grooves of the dental anatomy can be only reproduced by good elastomeric impression materials. Here we can see, for example, a test when we take 1 cent and this coin is impressioned by acetylcone. We can see the small details of the structure over this 1 cent. As the impression material flows and captures the details, it will be able to reproduce with fidelity these details on the surface. Silicones, unfortunately, are not so good. They release volatile products and mainly they release alcohol. Some modern impression materials, silicones, for example, oxazil from Kulzer, can remain stable for 21 days, but we shouldn't rely on these, let's say, claims. It's better to pour the impression within the first hour after taking it, because if it's left for a long period of time, it might distort because of the volatile release of the materials from this impression. It's better to use also mixing pads that properly measure the amount of base with the catalyst in order to obtain a good consistency and also good working time. For example, during the measurement of the putty with the scoop, it's better to take the spatula and take away what remains outside the spoon with two increments on two directions, because when it's fold, it might introduce error in the measurement. Polyether is another material which is hydrophilic material. It's not widespread in our country, but in Germany, till now, they use polyether and also in some other regions of the world. Why? Because it's hydrophilic by nature. It's very accurate, but unfortunately, it's a stiff material. It works good in moist environments, but it's very stiff and it's not widespread. It's currently replaced by silicones. Impression trays. We have different impression trays. Some of them are stock trays. Some of them are custom trays. The stock trays must be metal because the plastic trays are amenable to distortion. Some of them are non-perforated, and we call them rim locks. They are used for special purposes. For example, when we use heavy body with light body. The perforated ones are used with the putty and the medium viscosity, or putty with light viscosity. If the patient has special anatomical features, we might also make custom tray, and this is of course the best way to take impressions, using custom trays that are properly fabricated only for the patient in this case. In the previous slide also, you have seen a tray that is called triple tray. The triple tray takes the impression of the upper teeth and lower teeth together with the bite in the same instance, but they are not so recommended because they might distort. Tray adhesives also are important. If they are used, they will guarantee that the material will stick to the inner surface of the tray. Of course, the tray should be dry before using the tray. So, which viscosity to select? It depends on the technique that we are using and the tray type. If you look at this graph that represents one manufacturer who makes or who produces different viscosities of silicones. The stiffest one is the putty, then we have the soft putty and the heavy body. All these three materials are, tray materials. They are introduced inside the tray. Then we have the monophase and the medium viscosity. The monophase can be used as a single impression material, while the medium viscosity also, which is a viscosity that is not so hard and not so soft, can be used together with other materials. For the light body, we have light body and we have also extra light body. So we should pick and choose the appropriate types of materials in order to take the impressions without problems. What are the common material errors? Sometimes voids might appear inside the impression materials. Sometimes pulls or drags, incomplete seating of the tray, and early removal. So the main topics of this lecture will be biology, gingival displacement, impression materials, impression techniques, and digital impressions. So we have different types of techniques that are used in order to take the impression. One of them is the putty wash technique, which uses two viscosities, two different viscosities, the putty, then the light body. And we have the simultaneous mix, which is the introduction of the heavy body together with the light body at the same instance. The two-stage impression material is the best one. And as you can see in this video, we start with trying the appropriate size of the tray. In this case, we are using metal tray, perforated, stock tray. We are coating the inner surface of the tray with the adhesive, elastomeric adhesive. Despite that it's perforated, but it's better also to use the adhesive if it's available, of course. Here we are using addition silicone, vinyl polysiloxane. We can tell that it's addition silicone because the putty consists of two jars, and we are taking equal amounts of each jar and mix together in order to obtain the putty consistency or the first stage impression. Some clinicians prefer to use spacer at this stage, and some of them prefer not to use spacer. The spacer might guarantee the thickness of the flowable or the soft material, but if the soft material is not appropriate, it might run outside the area. Pushing the putty inside the tray will guarantee that it will stick to the surface of the tray. You might use this nylon sheet, and you might also not use it, but if you don't use this nylon sheet, it's better to take a burr and enlarge the surface of the impression in these areas where the flowable and soft material introduced inside the tray. After waiting for 3 minutes, we can take it out, pulling the nylon sheet, and start mixing the light body. During the mixing of the light body, we'll bleed the cartridge at first to guarantee that both nozzles are open, the base and the catalyst. Then we should place the mixing tip. It should be yellow because the consistency or the viscosity of the cartridge is light body. If it's medium viscosity or monophase, the nozzle will be green. After injecting the light body inside the tray, we can place also the intrasulcular tip and remove the courd and inject the material inside the sulcus. Nowadays, if the sulcus is open widely, there's no need for this step. This is an extra step, because sometimes it's problematic for the dentist to join both layers, the one that is introduced around the teeth and the one that is inside the tray. Gentle pushing of the tray will guarantee that the impression material wouldn't distort during polymerization. We should wait at least 2 minutes after the recommendations of the manufacturer. The two-step technique is very good. We should introduce the putty first, then the light body second, and it will capture details with very good precision, the one that we have seen in the previous video. With or without a spacer, I prefer without a spacer, and the viscosity matters. It really matters. So to sum up, we have viscosities that are intended to be used inside the tray. These are the putty, soft putty, and the heavy body. We have consistencies that are intended to be used inside the tray and also around the teeth. They are called the monophase materials. The medium viscosity is also a material that should be used with other materials. Monophase can be used by its own without any type of putty. Light body material should be used around the teeth, and extra light also viscosity should be used around the teeth only. These are called tooth materials. And as you can see, each manufacturer produces these different types of viscosities in order to fulfill the desires of the dentist. And over these also, bite registration materials also is produced from vinyl polysiloxane from addition silicones to take the bite of the patient.
Rest. Put one of your
You
pre-cut
can see
plastic
in this
squares
video
centered on top
also
of the tray with the tongue
the
cut area between these
impression
arches. Try to cover up all exposed impression putty with this plastic sheet.
with the plastic sheet.
Place the entire assembly in the mouth and seat it into place first with hand pressure. Next, place 2 cotton rolls bilaterally at the bicuspid area and ask the patient to bite into them firmly. Manipulation of the lip can aid in the formation of this putty tray. Then after 5 seconds of firm pressure, remove that tray from the patient's mouth. Now, while this putty is still pretty soft, take off that plastic sheet and you can hand manipulate the putty just to remove any potential undercut areas or stretch and mold a more ideal tray shape. Basically, what we're trying to accomplish here with this step is the formation of a chairside custom tray.
So we have made a
Now
custom
start
tray
adding the
out of
cylindrical medium body
this
material
soft tray
directly
by
into the tray
placing
while
a
keeping the
soft
mixing
putty.
tip buried. You're trying to avoid air bubbles from becoming trapped. All of this is accomplished while the putty is still curing to aid in the eventual integration of both of these layers together. Now, this entire assembly is now placed back in the mouth and seated just with hand pressure. I'm gently pressing the chin and the cheek area, and that's going to help to flow the medium body material and just to remove any air bubbles that may be present. The most important technique requirement at this stage is to make sure that this tray is held in with hand pressure only. Don't ask the patient to bite on any props to hold this in place. The impression can be removed after it's set and check to make sure everything is in order. The same procedure steps can now be performed with the final step requires a bite registration of the patient's arches in centric occlusion. We do recommend the use of the Capture
bite
VPS Fast
registration
Oral Set
material.
Bite Registration Paste, spread out over the full arch, allowed to set, and then removed.
So we have the putty wash technique without a spacer. We should move the tray a little bit in order to create a space for the light body around the teeth. This is the first stage, the putty. Then after the introduction inside the mouth, since it's without a spacer, we should move it a little bit with rocking motion. This motion is very important. It will create enough space for the light body to be introduced in the second stage. Now we are injecting the light body inside the tray over the putty. And this way we are taking the final impression in 2 stages, putty wash technique. So to sum up, we have tray materials and we have wash materials. Tray materials are the putty and the soft putty, heavy body, and monophase also, while the wash materials are the medium phase, light body, and extra light body. And we should make the appropriate decision regarding the mixture of each one of them. The one-step technique uses the heavy body together with the light body. It's faster, but there's a risk of entrapment of the bubbles. And I personally don't like this technique. But we can see it on this video. We have taken away the cords, injecting the light body and the heavy body together at one stage. Dual arch technique or the triple tray technique, it's not so good since there might be a distortion inside the tray. The triple tray technique uses a special tray where the patient bites in maximum intercuspation, and in one stage we are taking the prepared teeth, the antagonist teeth, and the bite registration. But as I have said, it's not so good to use this technique. How to evaluate the quality of the impression? We should obtain clear margins, no voids, no tray show through. This means that the impression material should cover all the tray. If there are places where the tray is visible, this means that this part was pushing hard on the tissues. Infection control, spray and disinfect the impression with Clorox diluted 1 part with 10 parts of water and transported with a well-sealed plastic bag. Common clinical mistakes. If we take the impression with bleeding, this will lead to poor retraction, the wrong tray size also, moving the tray during setting. All of these are mistakes that might be committed and they will influence the quality of the impression. So the impression material should be free of bubbles, free of tears, and free of. So the main topics of this lecture will be biology, gingival displacement, impression materials, impression techniques, and digital impressions. Thin spots. Finally, we'll talk a little bit about digital impressions. Why digital impressions are growing? Because of the patient's comfort, especially patients with gag and reflex. There is no distortion of the tray, no distortion of the impression. There is immediate feedback. We can see the results immediately, and easy communication with the lab and also with the patient. The CAD/CAM scanners nowadays are introduced with milling machines, which is called the one-session dentistry. The computer-aided designing and the computer-aided manufacturing can be used by the dentist in order to make the restoration within maybe not more than 90 minutes. And these equipments are widely spread nowadays in different parts of the world, but they are quite expensive. 3D printed models also might replace gypsum products, and this is called the rapid prototyping or the 3D printed models. How scanner works? They capture images, they stitch the images over each other, and this is why in long arch or in full arch impressions, stitching the images over each other might introduce error. So software refines details. Sometimes the softwares might amend the errors that might be introduced inside these scanners. But anyway, new technologies are improving and introduced to the markets every day. Cheaper versions are coming to the markets with better visibility and better dimensional accuracy. Limitations of digital scanners, of course, deep margins. If there is a deep sulcus, the scanner can't reach the deep areas. Bleeding also and saliva. If there is a deep margin, it's better to use traditional impressions since the impression material can flow inside the sulcus. Do we need tissue management for digital scanning? Of course, we need. The same principles apply as for the conventional impression materials. We need the margins to be visible, dry, of course, so we need either a courd or a paste in order to, well, open the sulcus and then to use the intraoral scanners. This is the last slide of the lecture, and I hope it was fruitful and useful for you in your later studies. Bye-bye and see you soon in another lecture. So the main topics of this lecture will be biology, gingival displacement, impression materials, impression techniques, and digital impressions.